one of the biggest issues coming into the World Health Assembly was the issue of the Ebola response. And you'll remember back in January, our member states came together in a special session to talk about how the organization needed to make some changes in order to be better for future responses like the Ebola response. Because that was such an important issue for the future of the organization, we're going to spend a lot of time talking about it today. And we're going to approach the conversation from several different directions so that you have time to ask the questions you need. Remember, come to us on Twitter at hashtag WHA68 or hashtag SocialGood. Now remember, the Ebola response was of a magnitude we have never seen before. The organization in the past has responded to about 12 Ebola outbreaks in the last 10 years. Anyone who has done an Ebola response will tell you we have never had to build the number of Ebola treatment centers we did for this response, nor of the size. These centers have more beds than we've ever put in an Ebola treatment center before. So that tells you the exponential response that was needed to address what was happening in these three countries in West Africa. Now, these extraordinary steps and the extensive work of those communities are really what got us to where we are today, which is in a much better place. Joining me now to talk about the situation today and how the UN worked to support the intensely affected countries and moving forward, where we're going to, is the Secretary General Special Representative for the Ebola response, Dr. David Nabarro. Thank you so much for joining us, David. Now, David, you've been working in emergency responses for decades. What struck you the most when you took over this response? I believe it was last August.
Yes, it was the beginning of August, Christy, and I must say that the first thing that struck me was the size of the outbreak. I've worked on many different outbreaks in my time in public health, but never anything that was affecting this number of people. Secondly, the severity of the disease. Ebola is such a horrible infection, and when people get it, unfortunately, the time between starting to be ill and succumbing is relatively short unless treatment is put in place. And thirdly, the speed with which the outbreak was increasing. So size, severity and speed. And on the speed, you know that it was doubling in numbers of cases about every 3 weeks. A terrible feeling, because often it takes a week or two to get yourself settled into a role, and then after 3 weeks of working on this, I suddenly realized it's twice as big now as it was when I started. And so, because of these various factors, we had to move ahead with a really complicated response, one that required many different actors to pull together. And that's my fourth and perhaps most important point to you, is complexity like I've never seen before.
Let's talk about some of that complexity. What was it that really drove this outbreak to get to the size that it did before you were brought in?
Well, I think we're doing a lot of work now to understand it, but my quick summary is that the outbreak got into urban communities in July, and it was that spread within Monrovia and Freetown and a little bit less in Conakry, but also some of the smaller towns in the affected countries that really got the thing moving quickly. And that's when we started to see people being very ill in the towns as we were moving around. And secondly, it was also a big traditional approach to sickness and caring that we had to take into account. And so communities actually were needing to look at behavior at its very basic form, how you look after people when they're ill, how you look after people who die, and that added to the complexity and rapidity of spread.
It's something that we're going to get into a little bit later with some of our other guests, the uniqueness of the community and how they did have such a passion of caring for their sick.
Yes.
And what that contributed to the response.
Yeah.
It seems today we're in a much different place than we were back when you first started, and it was growing exponentially. Can you just tell our viewers where we are today with this outbreak?
So when the outbreak was at its height, let's say really the end of September, beginning of October, we were seeing nearly 1,000 people getting sick with Ebola each week. That is a huge number. Then at the beginning of January, the number dropped to about 150 per week. And then by February, March, the number was reducing even further towards 50 a week. Now we're bumping a bit from week to week. Some weeks it's less than 10, other weeks like last week it's up nearer 35. but we are really seeing the tapering off. And Liberia has already been declared Ebola free. That was May the 9th, a wonderful day. And now we've got a situation where it's reducing nicely in Sierra Leone, but we've still got some challenges across the border in Guinea, which we're working on very intensively right now to get that country towards zero as well. It'll take a few more months, Christy, but I'm confident that within those months we will see the outbreak come to an end.
You know, I think I've heard you say before that this last stretch is the hardest part.
Absolutely. Yes.
Elaborate on that for me a little
Yes.
bit. What are we doing to get to zero, and why is it so difficult?
So when you're at the most intense phase of an outbreak like this, you're focusing on trying to ensure that you can save people's lives, trying to ensure that if people do die, that their bodies are handled safely and in a dignified way. As you're gradually moving towards the end of an outbreak, you're having to identify each chain of transmission. You're having to know everybody who's been in contact with somebody who's got Ebola. It's like looking for a needle in a haystack in some ways. It's a very tough part of the work because you have to go into communities and work with the people to find those who are ill and to find their contacts and follow them up. It's detective work like nothing else. And perhaps most importantly, you can't miss anybody. It's no good saying we've done 95%, because as Dr. Margaret Chan, the Director General here, often says, it all started from one case, it could end with one case. And it's that absolute need to make sure that we go and cover everybody that really matters at this stage.
I have a question from a Twitter viewer, if I may ask you. Were there any issues with communicating control procedures to communities?
So thank you for that question. And I'd like to say straight away that's right on the mark, because these kinds of disease outbreaks can only be brought under control by the communities, by the people themselves. It can't really be done by the doctors and nurses, can't be done by the outsiders. It's got to come from inside. We often talk about community ownership. And of course, it was the communities owning the outbreak and collectively deciding they were going to change the way in which they do things that transformed the situation in Liberia in October and November last year. It's the community ownership that's transformed the situation in much of Sierra Leone and much of Guinea. But there have been some communities who've said, hang on a minute, we don't really want to change how we treat our sick. We don't really want to change how we handle our dead. Doing it properly matters to us more than taking precautions for our health. It's these communities, sometimes referred to as the reticent communities, who are the ones who we really have to work with carefully. And your viewer is correct in identifying that there are issues, and the most important thing is to tune in to the people, to work with them on the issues that concern them, so that they own the response and will be part of the response. And that can only be done through very gradual working and confidence building. And that's what we're doing now.
Okay, one of the things you were just talking about was what it takes to get to zero, the diligence of that last stretch. Yeah. But at the same time, in some of these places, as you've said, we've ended the transmission of the virus in many places, and they would be moving more into an early recovery phase. How do you work both angles? How do you help those that have been able to get rid of the transmission in their communities move into an early recovery phase?
Very, very clear. Thank you. And the viewers, this is an outbreak occurring in a part of the world that's almost as big as France. It's a huge area, but it's only a very small part, perhaps equivalent to the size of Normandy, where you actually have the outbreak still going on. But the rest of the place, people are getting on with their lives. Schools are reopening. Health clinics are beginning to start up again. And so what we've got to do there is to ensure that the services restart and recover, but in a safe way, so that they don't inadvertently get caught up again in a resurgence of the outbreak. So helping to get safe basic services going with good infection control, helping to make sure that the schools are open in a good way, helping to make sure that the agriculture systems are working again, the markets are functioning. That's what we're concentrating on right now. We call it early recovery. It's the countries, as always, that are in the lead, local civil society, faith groups and others who are very much out in front, and the international community very much focusing on supporting this early recovery so that as systems get back in place, they will be better than they were before.
It's really that return to normalcy, isn't it, of sorts?
But it's better
Yeah.
normal, better than before. I keep saying that because the normal wasn't good enough, unfortunately.
Good. And we're going to talk about that later in the segment as well.
Yeah.
We have another question from one of our viewers, and if you have questions for Dr. David Nabarro, the UN Secretary General Special Representative for the Ebola response, you can send them to us on Twitter. It's hashtag WHA68 and hashtag SocialGood. The next question we have from our viewers, what surveillance measures are now put in place to prevent future outbreaks?
Now, again, right on the button, that question, because it's surveillance that matters more than anything. And there are two approaches to surveillance. One is called passive surveillance, when if there's an episode in the community, the authorities are informed about it and then they respond by coming and helping to identify not just the person who's unwell, but also people with whom that person's been in contact. And then there's active surveillance, when you actually fan out in the community and look to see whether there are people who are ill from village to village, hamlet to hamlet.
Does that take specialists? I'm sorry to interrupt you, but does that take a specialist? This type of surveillance, the active surveillance, community surveillance?
Yeah, it does require specialist skills. Two reasons. One, you don't want to be identifying people who've got other conditions and then setting off false alarms, but at the same time you don't want to miss people. And secondly, you've got to be super sensitive, because communities don't really like people coming and asking lots of questions about what have you been doing and how you're feeling. And so it's got to be done in a really sensitive and well done and carefully done way. And that's why people who've got knowledge and skills are really important. And not only that, they need to have local language as well as an international language, because often communities will only communicate in local language. So the surveillance is happening. I'd just like one last point on that. The local community organizations, neighborhood watch committees, churches, mosques and other groups, they are really, really important in this kind of surveillance. If they're part of the response, if they own the response, then everything's okay. If they're not part of the response, then we get problems.
It's really about getting to the leaders and the influential people in communities.
And having them being comfortable, because if they're not comfortable, if they feel this is alien, this is outsiders coming in, they get very jumpy.
David, I'm going to let you go now. It is always a pleasure to see you. Thank you for the work you do.
Thank you, Christy.
Good luck going forward.